All right, everybody, welcome to Optometric Education Consultants National Webinar Series, Tuesday night edition. Tonight's topic is GCA, OMG, and TED, the autoimmune alphabet. Interestingly enough, Greg and I will be the co-speakers on this. Interestingly enough, Greg, I had some encounters of all three today. Where I had a test for GCA. We had a consideration, and we may order some imaging for suspected TED, thyroid eye disease. And I just got back, fortunately, negative results for ocular myasthenia gravis testing. So we're going to look at all of this tonight and try to get you all more comfortable with these autoimmune diseases that are more common than people realize. Now, my disclosures. The past 24 months, I've been involved in the Speaker Bureau for Bausch & Lomb, Bausch Health. Got no direct financial interest in anything we may talk about here. All relevant relationships have been mitigated, and I am co-owner with Greg of Optometric Education Consultants. Greg, you want to mention your disclosures?
Sure. I've lectured anywhere from Alcon to Dompe and advisory boards from Dompe down to Optometric Advisory Visionary Team. Received honorariums for those. I have no direct financial proprietary interest in any of the companies, but I would like to disclose my non-salaried financial affiliation with Pharmanex. That means I'm a distributor. I do sit as the chairman of Advisory Council for Diabetes and Macular Degeneration for Healthcare Registries. It's a outcome-based registry. Probably the most important that Joe already mentioned, that we're co-owners of Optometric Education Consultants. The three things I can mention is Joe and I independently prepared this presentation. The content and the format is presented without commercial bias and does not complain any superiority if we do mention any products. And Joe and I have had all of everything, and all financial relationships have been mitigated.
All right, well, let's start looking at a couple patients. The first one's a 74-year-old male who presents with the worst headache of his life to an emergency room in a Veterans Administration hospital. Now, he initially sees a physician assistant who is supervised by the emergency department physician, and she diagnoses him with temporomandibular joint dysfunction, which was, I don't think, consistent with a complaint of worst headache of his life. Now, he was treated initially. He came back over a number of visits. Through a 3-week period of coming back, he had seen the original physician assistant, the ED physician, a cardiologist, a nurse practitioner, and 3 optometrists. Now, when we look at the totality of all of his symptoms that he presented through these varying visits, he at different times complained of eye ache, jaw pain, scalp pain, facial pain, somnolence to the point he fell asleep while eating his food, malaise, and jaw claudication. He was initially diagnosed with temporomandibular joint dysfunction and given a nonsteroidal anti-inflammatory. He came back not feeling any better. They find a tick on him. He is in a Lyme endemic area. Now they diagnose him with Lyme disease and put him on doxycycline. Now, as you look through the record, various things have been written, and written in the record was vasculitis, such as temporal arteritis, highly unlikely, not the GCA. However, somebody did order a sed-rate C-reactive protein, which when they came back were both elevated, but there's no indication anybody ever reviewed these test results. Ultimately, an optometrist made the diagnosis in the face of some contradictory findings, got the appropriate treatment, but unfortunately it was too late. The patient went bilaterally blind. 58-year-old male on a Thursday, 9 a.m., presents with vision loss in the right eye, diagnosed with bilateral ischemic neuropathy, right eye worse than left. He has mild headache and pharyngitis. Now, recommended was an OCT that was ordered to be performed the next day. And sed-rate C-reactive protein and platelets were also mentioned, but they were not officially ordered. On Friday, an OCT is performed by a technician. Saturday, the optometrist looks at the OCT, identifies disc swelling, greater right eye than left eye, and I guess have the come to Jesus moment. Faxes a letter to the PCP to get serology for giant cell done ASAP. The only problem is it's a Saturday and that office is not open. Sunday, office is not open, nothing happens. Monday, PCP reads the message, orders serology and carotid testing set for the following Wednesday evening. Tuesday, patient works up now with profound vision loss in the left eye, walks into an ER, gets all the tests done, everything is elevated. He had temporal arteritis. He ended up legally blind. 72-year-old female presents 6-week history of scalp pain, fatigue, weight loss, transient ischemic attacks in the right eye. Goes to an optometrist with sudden vision loss in the right eye. At that time, finding is no light perception in the right eye, 20/20 in the left eye. Diagnosis made papilledema of the right eye only. Plan, refer to ophthalmology the next day. Next day, patient goes to ophthalmologist. Now, no light perception in either eye from an arteritic bilateral ischemic neuropathy. 68-year-old female, 1-month history, sore throat, cough, ear pain, all unresponsive to antibiotics. Suddenly loses vision in the right eye. Neurologist sees a neurologist who diagnoses a Horner syndrome. That doesn't explain the vision loss. Is referred to ophthalmology, who diagnoses a central retinal artery occlusion, and that was it. So there's no workup. There's nothing that can be done. You've had a stroke in the eye. Now, a month later, patient has sudden vision loss in the other eye, and when a more thorough history is done, we find patient was not eating for 6 weeks prior to the initial visit because she had pain while chewing. All right, left eye has no light perception with ischemic neuropathy. There's a pupil-involved third nerve palsy, hypotony, and of course, the pre-existing Horner's and artery occlusion. Testing was done. Said rate was markedly elevated at 114. There's a positive temporal artery biopsy. The patient was put on high-dose steroids, felt better almost immediately, but had no visual recovery. 78-year-old female, 1-week history, occipital and jaw pain. Family practitioner puts her on NSAIDs. 2 days later, she has 1 hour total vision loss, both eyes, midnight in the coal mine. The right eye recovers, left eye does not. Family practitioner immediately discontinued the NSAIDs and referred to ophthalmology. Now, ophthalmology triage said, it sounds like an NSAID reaction. Wait a week for the NSAIDs to wear off before you come in. Next day, she goes blind in her remaining eye with a SAID rate of 117. This is a patient I saw not all that long ago. 70-year-old male was seen by actually my resident in another office in our practice. The patient complained of intermittent horizontal double vision. She initially diagnosed him with a decompensating fourier. Now, it got worse the next day, so she called me and asked me to see the patient immediately. And when I see her, he has an isolated left 6th nerve palsy. He's got a mild abduction deficit and a non-competent isoposture. He's also complaining of retroorbital pain. I think he's also diabetic. So presumptively, it looks like an ischemic vascular palsy. And I explained to him that these things tend to get worse over the course of a week. They're really no better in 2 weeks. They don't do anything for about a month, and after about six weeks, you start to show some improvement. We're going to keep an eye on you, make sure that you follow this course. And I told him it's most likely going to get worse the next several days. And I explained to him there's a medical supply store right outside my office. Go right ahead and get yourself an eye patch. You're probably going to need it. So I scheduled him for a week follow-up, and he comes back in a week. I'm expecting a pretty significant abduction deficit, but actually it's better. His double vision is now really only intermittent, and that retroorbital pain is now really being described more as a frontal headache. And I went through my history. No other symptoms suggestive of giant cell arteritis. I order the serology. Everything comes back elevated. SED rate 68, CRP 12, platelets 420. Got on the phone to his internist and we had a conversation. So we put him on 60 milligrams prednisone. Now, I did order a temporal artery ultrasound, which ultimately came back negative. But this is more of a clinical diagnosis. And I can tell you, he felt great on the steroid. His headache and his double vision disappeared almost as soon as he started taking the steroid. So ultimately, the PCP and I referred him to rheumatology for ongoing giant cell arteritis management. Now, why wasn't it an ischemic palsy? It just got better too fast. Ischemic palsies just don't do that. So don't forget, or I should be aware, double vision, ophthalmoparesis does happen pretty commonly in giant cell arteritis. There's about a 27% incidence in diplopia in patients with giant cell. Now, most of them, 88%, are caused by cranial neuropathy, either cranial nerve 3 or cranial nerve 6, most commonly. Cranial nerve 4, not as common. Orbital apex syndrome, polyneuropathy, or sometimes they don't know. There's no determined cause because it can be intermittent, not present during the examination. So intermittent double vision is very characteristic of giant cell arteritis. Now, diplopia will resolve spontaneously in 20% of the patients, and all will resolve with treatment with steroids. Sometimes patients will resolve immediately. Sometimes they take a little bit longer. And IV steroids give a faster resolution of the diplopia than oral steroids. And not everybody gets double vision, and it is often intermittent. So let's look at some of the initial symptoms in giant cell arteritis. I think we all know about headache. And headache is not really localized. We can't say it's always temporal head pain. It doesn't have to be temporal head pain or temporal scalp pain. It can be on the right on the top of the head. It can be in the occipital region. It can be in the frontal region. It's just they do have head pain and scalp pain. Polymyalgia rheumatica is a rheumatologic autoimmune disease, which really is probably a milder manifestation of this condition. There are different ends of the spectrum of the same disease process. I have in here chair, hair, stare, and fair. Let me explain what all that means, because if you talk to your elderly patients and ask about their general constitutional symptoms, if you don't probe the history properly, we can actually miss a few things. I had a fellow who had very few symptoms. He had an arteritic ischemic neuropathy. And I asked him, does anything, he was really kind of giving me no to all my history questions. And when I asked him, I finally said, does anything really hurt? He goes, Doc, I'm 88 years old. Everything hurts. So think of it like this: chair. It's hard for them to get out of the reclining chair. Hair. It hurts when they comb their hair. Stair. It's hard for them to go up the stairs. And I put in here fair because we also used to think that this was a Caucasian disease, and it really isn't. And the reason we thought this was predominantly a Caucasian disease is because of a population study that looked at patients with giant cell arteritis, among other things. They found the vast majority of the population in this study were Caucasians. Caveat was, it was done in Olmsted County, Minnesota, where most everybody is Caucasian. Now, when the same population study is looked at in Baltimore, about 30% are people of color. And I have seen, probably within the last year, my first patient of color with biopsy-proven temporal arteritis. Fever of unknown origin. Visual symptoms without vision loss. They have transient ischemic attacks or transient blackouts in one eye, or both eyes. Transient double vision, which may not be happening during your exam. Weakness, malaise, fatigue are all common. Now, what do all these things have in common? they can all have a normal examination. So we want to try to pick up these patients and get them diagnosed and treated when they're in this prodromal stage, before they have vision loss. Our goal when a patient comes in with giant cell arteritis and vision loss is we want to prevent bilateral blindness. Better would be if we can identify these patients when they're in our chair before they have vision loss. Now, here's one of my own patients. I saw her several months ago. She was 78 years old. She comes in for a comprehensive annual examination. It's not an emergency visit. She has a little bit of dry eye. She needs a small update on her prescription, her glasses. But she mentions, not a chief complaint, but she mentions intermittent right scalp pain. It happens in the morning, dissipates throughout the day, doesn't happen every day, happened today, already dissipated. Her exam was completely normal. And I actually wrote in the chart, doubt GCA, but will obtain serology. And SED rate comes back elevated, 68. CRP is double what it should be. Got her on 80 milligrams prednisone via her PCP and got her referred to a rheumatologist. Caveat, giant cell arteritis is the most common chronic adult vasculitis. And this is probably related to polymyalgia rheumatica. It will come, it will go, it will self-resolve, it will exacerbate. So it is not always an acute disease. It can be a very chronic disease. So we have to be aware of that. So it's the most common chronic adult vasculitis. In my practice, I'm in Venice, Florida. I see more patients over the age of 90 than I do under the age of 23. Probably the average age in the practice is about 65 years old. I consider giant cell almost on a daily basis based upon some of the symptoms patients present. I probably test for giant cell once or twice a week. My threshold for testing for this disease, very low. And when cases like this come in that I nearly miss, my threshold goes down even further. So if we look at the vascular distribution, we got the carotid artery, we got the occipital artery, ophthalmic artery, temporal artery, facial artery, lingual artery. Understand head pain can be anywhere. It can be temporal, can be occipital, it can be in the neck, it can be in the ear, can be in the jaw, can be in the scalp, anywhere. A lot of times I have patients complain the top of their head hurts or the back of their head hurts, the scalp region. So it is not localizing. Any head pain is significant when considering giant cell arteritis. So Greg, that brings me to my first polling question. What is the minimum age to suspect giant cell arteritis? Is it 40 years old, 50 years old, 65 years old, 72 years old, or 80 years old?
So, Joe, as this question is rolling in,
Yes.
I just realized there's always updates going on that in our area here, in our platform, there's at the top a chat box. There's a question and answer. There's a polling section, questions and notes. So I put in there to the audience, hello all, thank you for trusting your education with OEC. I'd like to see, I want to see if it's working. Can someone out there as they answer the poll, put a comment in there? I want to see if it's working, because that's where we can put the questions for the synchronous part. Hey, thanks,
So
Chris. All right, it's working.
There's a chat box and a question and answer.
Yeah, now there's both.
And for our audience, we started off, there's a chat box for this new platform. Then it disappeared, and there was a question and answer. Now we got both. Sometimes it's like working in the Carnival Funhouse. You don't know what you're going to get.
So, Joe, as this question's rolling in, this was the question I had to you is, since I've sat through your lecture multiple times, we've done this live, so on and so forth, and I appreciate you made me feel so much more comfortable managing my GCA patients. Was it, once you have the answer, has it always been this age over the years, or has it changed or fluctuated? That would be my question.
It is kind of fluctuated. There are a lot of misconceptions, and we're trying to change those so the disease doesn't get missed. But yeah, it has fluctuated, but right now it is in the literature pretty consistent. Do we
Okay,
have
so
results?
yep, I just posted them.
Mhm.
We have 5% for people saying 40 years old, the majority at 61% saying 50. Then we have the next one being 33% 65. And then one person just saying 80. So you got 50 and 65, and then 5 responses at 40.
Excellent. Well, Greg, I think it turns out to be a good question. If you look at the literature, the average age is 72 to 73, but really the minimum age is 50. So today, any peer review literature on giant cell arteritis or arteritic ischemic neuropathy, I can virtually guarantee somewhere in the paragraph, probably the first sentence, will be described as an autoimmune disease afflicting patients over the age of 50. So that's the magic number, is 50 years old. Now, the older you go, the more common it is. It is more disease of the elderly, but by definition, elderly is 50 years old. Don't hate the player, hate the game. Always remember, any acute vision loss in the elderly is giant cell until proven otherwise. And by definition, as we all know right now, elderly is 50 and above. I think probably the youngest I've encountered that I can recall is around 57 or 58. If you had something in 50, 51, 52, I'm going to be dubious, but I will acknowledge it, because if we are wrong and we have devastating consequences we see here, any literature will say 50 and above. And if you're ever wondering what to do, you wonder yourself, is this something I should act upon? Just read the history to yourself. You read it yourself, read it out loud, read the chief complaint out loud. 78-year-old female presents for a routine eye exam. Patient mentions some dryness and fluctuating vision when she blinks. She feels her distance vision is off a bit. She mentions temporal headache. Done. Because if you don't consider it, at least consider. Now, you can write in there that you investigated it and you feel that it is not pertinent. It is a small quality of life complaint. It might be associated with allergy, whatever it is. Either explain it or do something about it, but don't let it sit in the history, because if we miss the disease with bad outcome, it is going to be a medical legal nightmare. I've dealt with 4 cases so far of alleged mismanagement of temporal arteritis. So what is giant cell arteritis? It's 10 out of 100,000 people, or maybe 1 out of 10,000 people over the age of 50. And there's an increased interleukin-6 with inappropriate T cell migration, and it causes cytokine release into the adventitia. Now, these are medium and large arteries. The branch retinal arterioles are too small. They've got to have this muscular wall for these inflammatory cells to infiltrate. And what's going to do is cause an inflammatory cytokine release and a degenerative breakdown of the vessels with a collapse of the lumen. There are 3 clinical phenotypes. There's cranial GCA with people with patients we're going to be seeing who have vision loss, they have double vision, and they have transient ischemic attacks. There's large vessel GCA, which gives systemic symptoms, and as I mentioned, a milder form of the disease is polymyalgia rheumatica, which does float through my practice quite a bit. These are patients who already have diagnoses. They probably already have rheumatologists. They might be on a low-dose steroid, but I've always told them, sudden vision loss, transient vision loss, double vision, or headache, you need to let me know immediately. Making clinical diagnoses with vascular studies as well as lab studies. The most common things we're going to be ordering are sed rate, C-reactive protein, and platelet levels. There are other studies such as complete blood count, and which will give you your platelet levels, and liver function studies, which I find to be a little bit less helpful. Greg, that brings me already to polling question number 2, which is not found occurring in giant cell. Is it ischemic neuropathy, tongue claudication and necrosis, retinal artery occlusion, isolated cotton wool spot, fever, night sweats, dry cough, or can any of them be found in giant cell?
There are no polling questions, or there are no questions in the chat box.
Good. Okay.
I don't see any questions in the question and answer box. If anyone wants to put a question, since we have access to the chat box, it's a lot easier to navigate the chat box. Please put them in there. Let me see what's going on with the polling question. Looks like we got people rolling in. Okay. Questions. They're it's a little slower, maybe because there's a bunch, but looks like
Which is not found occurring in GCA.
All right, looks like we got the majority, Joe. I'll display. And 69% have gone with H. Any of the above can be found. The runner-up would be not found, would be dry cough, fever, night sweats, isolated cotton wool spot, retinal artery occlusion, and just a handful, like 4, 3, 6 responses. So the majority are any or dry cough.
Really, any of the above can be found in giant cell, essentially, and more. I mean, and many more. So this is a multi-symptom, multi-system disorder. Clinical presentation of vascular new onset headache, scalp tenderness, claudication of the jaw or tongue or the upper extremities, more the upper extremities than lower, more arms and shoulders than legs. Rheumatologic stiffness of the neck, shoulder, pelvis, possible muscle weakness, which is worse in the morning and exacerbated by movement, and that's polymyalgia rheumatica. Constitutional fever, night sweats, fatigue, depression, dry cough, loss of weight, loss of appetite, ischemic neuropathy, cotton wool spotting, artery occlusions, cranial nerve palsies, and extraocular muscle ischemias. Now, what are the risk factors? Of course, age over 50, Northern European ancestry, females about 2 to 1 to male, family history, HLA polymorphisms, history of polymyalgia, which I think is an early form of the disease, vascular disease, estrogen deficiency, low body mass index, but that's probably because they aren't eating, they're anorexic, and of course, smoking. Common presentations, ischemic neuropathies, anterior ischemic optic neuropathies, very common. Common findings, cotton wool spots, ciliary retinal artery occlusion, central retinal artery occlusion, cranial nerve palsies, and often extraocular muscle ischemias. And then we start getting the rarer things that can occur: ocular ischemic syndrome, Horner syndrome, tonic pupils, and the very rare, but we're going to be seeing most of the common and very common. So making the diagnosis, sed rate, it's a inflammatory marker, elevated typically in GCA and polymyalgia rheumatica. It has been considered the gold standard, but we're drifting away from that a little bit. It's good for monitoring treatment, but a normal value does not exclude giant cell. C-reactive protein is produced by the hepatocytes, is elevated in inflammation, infection, and injury. very good with arteritic activity, and it isn't interfered by some of the things that would normalize a SED rate. Probably more sensitive for giant cell. And platelet count, mild thrombocytosis is common. Platelet count greater than 400,000 is more helpful than elevated SED rate for ruling in GCA. And a normal platelet count is more accurate than a normal SED rate for ruling out GCA. So SED rate, C-reactive protein, platelets, most commonly done for giant cell arteritis. And there's a couple other things that can also be used: plasma viscosity, fibrinogen, blood count, antiphospholipid, anticardiolipin antibodies, liver function tests. I don't typically order these. I usually stick to the ones we just discussed. Now, temporal artery biopsy has been the gold standard for diagnosing giant cell. When they're there, it's got a specificity of 100% and a sensitivity of 77%. But the false negative rate, can be anywhere from 9 to 60%. Only about half the patients will have giant cells in their biopsies. There can be skip lesions. Maybe there's poor pathology. You get the report back, there's, temporal veins normal, you idiot. Maybe there's a poor pathologist who doesn't read it properly. Now, read the report. You may say no giant cells, no active arteritis. But if it says focal interruption of the internal elastic lamina, that's a healed arteritis. Now we're getting more into temporal artery ultrasound. It's a lot easier to do, it's easier to obtain, probably just as sensitive and specific for temporal arteritis. And they have three things on the ultrasound: the compression sign, the halo sign, and reduced velocity of flow through. And I'll explain to you what they are. In a temporal artery ultrasound, you have to have a good sonographer who knows how to do this test, and they will do it on both sides. There's no loss of vessel, there's no biopsying. Very good. There's the halo sign around the temporal artery. You got this very dark area, and that's because the vascular wall has been thickened. So looking for a halo sign. Compression sign, they'll take that transducer and push on it to see if they can collapse the temporal artery. If they can, that's a negative result. If they push on it and it still is visible, it's from the thickened wall, and that is a positive sign. So a compression sign, halo, and they also look at the flow through. So the European League Against Rheumatism, EULAR, is recommending the use of temporal artery ultrasound as a first-line imaging examination. In fact, in Europe, they've pretty much gone away from ultrasound, from biopsies, and they're really just using ultrasounds. We have a few labs here, but in our area, we happen to have, Greg, a vascular surgeon. They've got a good ultrasonographer. I can get the patient in same day if it's an emergency, or next day, and they have great turnaround, great response. So really, we're doing more ultrasound than anything. Now we look at the American College of Rheumatology and EULAR for diagnosing giant cell, the criteria. Absolute requirement, you got to be over the age of 50. Now, you score all these items. A score of 6 or more can be used for classification of giant cell. You look at it: sudden vision loss, jaw claudication, scalp tenderness, maximum SED rate over 50, C-reactive protein over 10, positive. It's pretty easy to add these up and get over 6. And this, for those out there, this did not make the handout. So if you want to take a picture of this screen right now or screenshot it, go right ahead. But this is the criteria for diagnosing giant cell arteritis, or at least highly suspecting the disease. And it doesn't take much to get a score of 6 or more. So diagnostic delay of giant cell, about 7 weeks. If it's systemic, it's a lot longer. Treatment for non-visual large vessel giant cell that they've not lost their vision, somewhere between 40 and 60 milligrams of prednisone by mouth. If they have cranial or visual findings, they're usually going to be admitted for 3 days, 12 doses, gram a day, 3 days, methylprednisolone. And tocilizumab is a biologic agent that has been investigated and approved as a steroid-sparing therapy. It reduces the steroid load. Problem is, it's on a restricted formulary, very expensive. It's only used by rheumatologists, and nobody is really sure when to stop this treatment. But tocilizumab is a biologic Actemra. It was for psoriatic arthritis. It is now also being used for giant cell arteritis, and it reduces the amount of steroids over the course of the first year. It doesn't replace treatment with steroids, but reduces the amount of steroids. So giant cell is a clinical diagnosis. A negative ultrasound or biopsy does not rule out the disease if other features are present. So I'm going to spend my last couple minutes here talking about myasthenia gravis, or specifically more ocular myasthenia, or the OMG. This is an autoimmune disease where maverick antibodies are being produced, and there's antagonism and inhibition. So what happens is a nerve impulse travels down to the neuromuscular junction. It releases acetylcholine, which interacts with the receptors on the skeletal muscles, propagates the nerve impulse, and an enzyme called acetylcholinesterase will come in and break this all down so that it can be sequestered into vesicles to be used again. In myasthenia gravis, these maverick antibodies will block these receptors. So acetylcholine is released, but it has an incomplete ability to stimulate the muscle. And then anticholinesterase will come in. This enzyme will break it all down and send it back to be uptaken into these vesicles. So there is an incomplete response and a skeletal muscle weakness. Greg, that brings me to polling question number 3. What's the most common demographic for myasthenia gravis? Is it younger women, older men, older women, or younger men? Or can any demographic develop myasthenia?
Okay.
So what's the most common demographic?
The answers are rolling in.
Excellent.
So, Joe, while this was running, we have some people that don't have the chat box. We have some people that do have the chat box. So just part of the mix. So,
Part
but
of the
there,
carnival fun house.
there you go. Here's a question. I had a patient with myasthenia concern with being dilated. She found some evidence that dilating drops can cause a MG crisis. Is there any validation to this claim or validity to this claim?
I've not come across that, nor have I experienced that myself.
All right, let me go back to the polling question and let me see what it looks like. Oh, we got a nice amount of people. We have younger woman, 15%, older men, 18%, older woman, 20%, 3% younger men. Any demographic can develop myasthenia gravis at 45%.
And that turns out to be the correct. Any demographic can do it. We used to think that this was strictly a disease of younger women and older men, or what we used to refer to as backstage at the Rolling Stones concert. But we now know that older women and younger men can have it, so it really can occur at any age. It's an autoimmune disease. In fact, as I said, it affects the neuromuscular junction of the skeletal muscles. There's probably an involvement of the thymus gland. It's about 15 out of 100,000 now. In my experience, Greg, in the last 3 to 4 years, and certainly 3 years, I've come across this or dealt with this more than I have in the last 30 years. And maybe makes me think that we've been monkeying with our immune system with COVID and the vaccines. But again, I'm not a conspiracy theorist. All I know is I see a lot more of this than I ever have. Ocular form, anywhere from 15 to 30% involving only eyes. Systemic form, 70 to 85%. Now, if it stays in the eye alone, and the range has been challenged. Some people say 2 years, other people say 4 years. If they make it through that period of time, it will remain only ocular, will not become a life-threatening general disease. But 90% of people with systemic or general myasthenia will develop eye signs, and 70% will develop life-threatening disease. They can't swallow, they can't breathe. It affects the EOMs, the orbicularis oculi, and the levator, but it does not affect the pupil. Anything involving the pupil is not myasthenia gravis. So we have a painless variable double vision and ptosis. And this can be a difficult disease to diagnose or even suspect. So some of the OMG, that's the part of our alphabet, isolated muscle weakness, and it could be one of the muscles involving 3: inferior oblique, medial rectus, superior rectus. You don't get aneurysms that cause isolated muscle palsies for 3. Ptosis, or apparent contralateral lid retraction, where they use their frontalis to help lift up their lids. Pupil sparing third, remember the pupil's not involved. 4th or 6th nerve palsy, skew deviation, multiple cranial neuropathies, or variable cranial neuropathy. Sometimes you think that you're going crazy. You look at a patient and you're looking at a patient with a right abduction deficit, and 2 weeks ago you wrote down left abduction deficit. Did you make a mistake, or does this actually change? Or a pseudo internuclear ophthalmoplegia. Here's a patient of mine, 84-year-old male, 2-day history of dizziness. He had been scanned and underwent serology at an ER, which was normal. I don't know what they actually did. And he had a sudden onset of horizontal double vision. You can see he does not adduct, and that was his only deficit there. Now, that would be medial rectus, and we don't have medial rectus palsy. So let's look at his motility here. So we have an underaction right there. He can look up. He has no ptosis. He doesn't have a third nerve palsy. He just happens to have this adduction deficit. I did convince myself there might have been a little bit of abducting nystagmus. So we're looking at either on him a left internuclear ophthalmoplegia or a pseudo internuclear ophthalmoplegia. And if it is an internuclear ophthalmoplegia, that's mesencephalic disease and probably an infarct. So I ordered a contrast enhanced MRI of the brain, which came back normal. When I saw him a week later in follow-up, his diplopia had resolved, his motility was normal. So that tells me we're probably dealing with pseudo-internuclear ophthalmoplegia. At that point, I started testing for myasthenia gravis, anticholinesterase receptor antibodies, binding, blocking, and modulating are the 3 that we do. And out of all of them, the most important is binding. Now, everything was normal, but his blocking antibodies were elevated. They're still normal, very close to being abnormal. I ordered anti-musk. It was not performed. So likely this is a person who is seronegative with ocular myasthenia gravis. So signs that we're going to have are variability in presentation, Worsening throughout the day. It does improve when they rest and they wake up. You might have a contralateral lid retraction. Osher's peak sign. I tell patients squeeze their eyes really, really, really tight. And as they're doing that, they may start to peak. The muscles fatigue very quickly and their eyes start to peek open. Kogan's lid twitch, I have them look up and down and the eyelid would bounce up above the globe, right? It twitches up. Or just have them look up and see if the eyelid fatigues and the ptosis increase. I can tell them also squeeze your eyes real tight, and I try to pry them apart. If it's difficult for me, it probably is not ocular myasthenia. If it's weak, it could be. Now, I'll talk about the ice pack test a little bit. I don't really do that a lot, Greg. So there are another number of other things. Diagnosing myasthenia. We used to do it with a tensilon test, that ammonium chloride, where that was injected, and if the diplopia and or the ptosis, usually the ptosis, if that improved, that was pretty diagnostic. Bit of a dangerous drug. We don't use it any longer. But one thing that we have used for quite a bit was the ice pack test. Now, I said when the antibodies block the receptors, acetylcholinesterase can't do its job. Acetylcholine can't do its job, but acetylcholinesterase, the enzyme that breaks it down, can do its job. So it breaks down the acetylcholine. Now, there are two ways to inactivate an enzyme. You can supercool it or superheat it. So what we used to do, and this really only works for ptosis, is put an ice pack on the eye for about 2 minutes. It can be very uncomfortable. And if it improves ptosis, it can be it can be very diagnostic. One thing I've not tried is a heat mask. I have read the literature that has indicated that it does work. If you've got a Bruder mask or something similar, you can put it into your microwave in the oven, put it on, and if that can improve ptosis, that can be very helpful too. My next one, if I remember to do it, I'll probably do it with a heat mask. But a negative result with any of them doesn't rule out the disease. Really, what we're doing now are acetylcholinesterase antibody assays. Binding, blocking, and modulating. Seropositive, they got the disease, and it shows up on the serology. Seronegative, they got the disease, but it doesn't show up. Everything comes back normal. So it becomes a clinical diagnosis or suspicion. Now, up to about 12% of myasthenic patients are seronegative. Most of these are the ones with ocular myasthenia. More likely to have seronegative ocular myasthenia gravis than a seronegative general myasthenia gravis, where it's affecting other parts of the body. So binding is the most sensitive and specific for ocular myasthenia. I order all three. I highly recommend that you make sure that that they really need these and that the patient's insurance will cover it. In my area, we have one insurer. It seems like one won't cover these tests. They say that it is experimental, and I usually have to write letters and go to war on the patient's behalf with this insurance. Now, binding antibodies present about 85% of general myasthenics and about 40 to 70% of ocular myasthenics. Now, someone who's seronegative now might become seropositive later. And I also try to order, and it doesn't always get performed, anti-MuSK antibodies. 15% of seronegative patients of these seronegative patients, about 40% will have anti-MuSK antibodies. So I do consider this in addition with the binding, blocking, and modulating. I don't do chest x-rays or chest MRIs. Once we make the diagnosis, I turn that over to the neurologist who has got experience and skill in neuromuscular disease. But about 70% will have some excess thymic tissue left over. About 20% will have a thymoma, which is a benign tumor. But these patients often have other autoimmune diseases. So managing it, they of course need a medical evaluation and then to go immunosuppression to reduce the antibodies. The anticholinesterase inhibitors are the most common. There seems to be no rhyme or reason to how the neurologist prescribed the dosing. Now, patients tell me that the neurologist, yeah, take 2 pills. If it doesn't work, take 4 pills. And if it doesn't work, take 6 pills. Steroids can be done, prednisone. Plasma exchange to filter out the antibodies has been attempted, and intravenous immunoglobulins are often done. Now, thymectomy, removing the thymus gland, is only about 50% effective. It can cause remission, but it doesn't necessarily cure the disease. So the myasthenia or ocular myasthenia gravis take home is it is always a differential diagnosis of ophthalmoparesis. So with that, Greg, I think you're going to take over for a bit. I'm going to stop sharing.
I think that is correct. And I will share. All right. You seeing my slides?
I am. You're good.
Perfect. All right. So I'm going to be taking care of the thyroid eye disease, the TED part of this part. Most of my lectures have manifested, based upon probably things I've missed or referrals that have come in. And this one was more or less the ones I have missed over the years. I had these patients coming in that I thought had inflammatory dry eye, had some type of chronic, perennial allergic conjunctivitis. And basically it was just the soft tissue involvement from thyroid eye disease. I'd look back, I would see that they're on Synthroid. From time to time, I would test them for the antibodies that we'll talk about tonight. And so that's pretty much how this lecture birthed. And the more I kept learning, It started off as an hour lecture and it turned into a 2-hour lecture, but I'm going to give you the abbreviated part tonight. Another way that I've learned over the years is that I'd have people come up and they would say a good lecture if they can write 2 or 3 pearls down. And I hope that you get 2 or 3 pearls from Joe's part and 2 or 3 pearls from my part. But a way that I can judge a lecture now is, can you write any patients down? And in this part here, I think you'll think of a few patients and hopefully you'll write a few patients down when we talk about thyroid and thyroid eye disease. Now, I'm going to kind of talk 2 different languages here tonight. Allopathic medicine is Western medicine. That's using, opposites cure. It's what we all grew up in optometry school. High pressure, use glaucoma meds. Have a sty, use an antibiotic, have an inflammation, iritis, cycloplegia, and steroids. But I learned this at my functional meeting that I'll be attending here in December. And you'll see where they tied in, I'm going to talk a little bit about oxidative stress, but, thyroid is a hormone. And the one doc here talks about the hormonal symphony, where insulin and cortisol and thyroid and sex hormones all tie together whenever we come there. So we want to kind of remember these all kind of play together. In America, we kind of have maybe our endocrinologist, but maybe one that more specializes in thyroid or diabetes and so on and so forth. But let's all remember that they play together. Here's that meeting that I was just referencing that's out there that I was talking about. And that's where I heard this MD, Philomena Trinidad, speak. And she was talking about the hormonal symphony, and she's kind of trademarked this in a sense. Insulin is kind of here at the top, the adrenals, thyroid, sex hormones, and then estrogen metabolism. There's a lot of estrogens in our foods affecting men and women, but these all play together. And her fun story that she told was, there was a primary care doc trying to unravel this thyroid issue, maybe saw an endocrinologist and they were, playing around with Synthroid. But when she saw the patient and kind of looked at him as from a functional standpoint, the patient was insulin resistant. And when they fixed the insulin resistance, Then what fell into place was some of the adrenals, but more importantly, their thyroid, what looked like a disruption or dysfunction, fell into place, and it was more insulin resistant, creating the thyroid issue. So it was just a nice little story to remind us that these hormones all play together and are important. So in thyroid and thyroid eye disease, I have a polling question here that is, oh, wrong one. Hold on. There we go. Does everyone coming in taking Synthroid, are they at risk for thyroid eye disease? Everyone coming in taking Synthroid as a patient, are they at risk for thyroid eye disease? Yes or no? And then just ask yourself, where is thyroid eye disease located? What part of the eye? It's not a polling question, but it's just a question that I'd like for you to think about. And when I do this live, it's always kind of neat to kind of watch the discussion and watch everyone weigh in. But ask yourself, where is it located? Nothing as a polling question. You don't have to put anything in the chat box or the question and answer. And then, is everyone on Synthroid at risk for thyroid eye disease? All right, I think we've got a nice amount of people.
Mhm.
We have 60% saying yes. We have 40% saying no. And let's see, I'll just close that question and close the display. So I'm gonna just kind of, and I'll let more go as we go here, but or I'll let more information out as we go. But is everyone on Synthroid at risk for thyroid eye disease? And I'm just gonna just say I think that answer would be no. I'll go with I think the 60% or the 40% that mentioned that. I would lean on that way. Reason being is that we're going to talk about how thyroid eye disease is an inflammatory autoimmune disease, and where is it located? In the orbit. So it's an autoimmune disease, and that's how it ended up in the autoimmune alphabet. And I'm taking care of the thyroid eye disease part. Is that it's an orbital disease, autoimmune, found in the orbit, and it's inflammatory. Now, let's say you're having a great day as an optometrist, and you do your confrontation fields, and um, and you find, they have a bitemporal hemianopia. You do the visual field testing and it confirms it. You find a small pituitary tumor. You send them for surgery. They remove the pituitary tumor. Now we don't have the thyroid stimulating hormone, thyroid releasing hormones coming down, talking to the anterior pituitary, but then there's no pituitary to release the thyroid stimulating hormone because it's been removed. That person's going to end up on Synthroid, but they're going to be, I guess, at very, very low risk or no risk of developing thyroid eye disease because they ended up on Synthroid because of pituitary tumor or and having it removed, and now there's no way of producing it, as opposed to an inflammatory autoimmune condition. Let's say you see someone with a scar on their neck and they've had thyroid cancer and they had their thyroid removed. Well, they can't produce T3, T4, the calcitrin. So they're going to end up on Synthroid. And so that person is not, at risk because that's not the autoimmune type of condition that's out there. And it's in the orbit. So let's go through a few didactic slides here. Remember, the thyroid is an endocrine gland. Now, for this lecture, there's more types of glands, but for this lecture, we're just talking about endocrine and exocrine. And remember, an endocrine system is controlled system of a ductless system. It's using hormones and chemical messengers that circulate in the body via the bloodstream. And so these are your endocrine glands. And you can see in here that thyroid falls within here. So pancreas is what I'm going to talk about on the next slide because it is both endocrine and exocrine. But you can see the hypothalamus, pituitary, thyroid, parathyroid. Now, exocrine means that it's using a duct or a tube to create, secrete digestive enzymes, for an example, into the digestive tract. So if you look at the pancreas, it's both endocrine and exocrine. Exocrine in the sense that it is secreting digestive enzymes in the small intestine. And the endocrine side of it, I think we're all aware of, is the insulin and glucagon that the pancreas produces. So the endocrine side is the insulin and glucagon, but then secreting those digestive enzymes. Remember, thyroid is endocrine using the lymph and blood system to send these chemical messengers. I think we all realize that the thyroid, it's located in the neck region, just below the skin and muscle layer, and it is the largest endocrine gland in the body. And its main function is to produce T3, T4, and calcitrin. So this is what I was just talking about. Here's your thyroid releasing hormone being produced in the hypothalamus, but there's no duct, there's no tube. It's just circulating through the blood and lymph to talk to the anterior pituitary to produce that thyroid stimulating hormone, which is then going to go through blood and lymph and talk to these receptors. These receptors are now important. Remember that thyroid disease, thyroid eye disease, is going to be an autoimmune. It's going to be that these antibodies, these thyroid antibodies that we're going to talk about here shortly, are attacking the receptors at the thyroid gland. So this autoimmune condition, and we can take a deeper dive into that at another time, a lot of it has become from like the leaky guts that are out there. And leaky gut, if we would just call it what it is, leaky poop getting into your lymph and blood system, your body has an immune reaction. We're starting to see more autoimmune in the Eastern countries, European countries, as the Western diet has made its way over there. So a little bit of thought behind where that comes. You can Google it. We won't discuss that too in depth at this point, but we're going to talk about that this is an autoimmune condition. And this is where a lot of the one of these lectures or part of this lecture where it was birthed from. This gentleman comes in and he says, "Hey, Greg, I'm not going to, maybe pay the copay, or I've been told so many times that I have a thyroid problem, and they keep testing me, and I don't really have a thyroid problem." So I said, "Okay, let's try and unravel what's going on." Obviously, you have some bulgy eyes here, some eyes that are bulging out. You got some lid retraction, not really red here, not really inflamed. But I said, "You know what? I think you just might be being tested the wrong way. I don't think you really have a thyroid dysfunction as in your T3, T4, and that's why it's coming out. But I do think you have a condition where it is attacking the orbits of your eye." And he said, "Okay, do tell. I would like to hear a little bit more." So I didn't turn this into a polling question to save time for tonight, but what is the most common cause of thyroid dysfunction? Just ask yourself, is it cancer? Is it medication toxicity? Is it surgically induced pregnancy or autoimmune? What is the most common cause? All of these will cause, I guess in a sense, a thyroid dysfunction. Cancer can infiltrate the thyroid, obviously surgically induced, some medication toxicity. Pregnancy is out there, and autoimmune. So I think you probably know, since it's fallen into the autoimmune alphabet, that autoimmune is the most common cause of thyroid dysfunction. Now, what happens in autoimmune? Well, autoimmune is the body produces blank that attacks itself. And this can be systemic attack. This can be organ specific. And in this case, it could be the thyroid's being attacked or the orbit of the eye. And what's causing that attack is antibodies. Or if we want to be really, really fancy as lecturers, we can say, ooh, immunoglobulins. Immunoglobulins are attacking those receptors or those tissues. So when it comes to thyroid dysfunction, you can have the primary where the gland itself is just not working. And maybe it's because of the autoimmune and these antibodies attacking the receptors. Maybe it was cancer. Maybe it was some type of toxicity like lithium toxicity. Maybe it was a pituitary tumor. That would be your secondary type of failure. and then maybe some type of closed head trauma, stroke affecting that hypothalamus, something up there disrupting that thyroid releasing, not allowing the thyroid stimulating to come down. And that would be your tertiary. So primary, secondary, tertiary, going from the thyroid gland to the pituitary to the hypothalamus. So this is a pretty important slide here. I'm just going to animate the whole slide. This is where, Joe and I lecture and have Andy Lee come in. So I'm going to steal his word. This is where we as optometrists can become the superheroes of helping to solve a lot of these mysteries with thyroid eye disease. A lot of people will test T3, T4, TSH, and that's not where this autoimmune disease lies. It lies within these antibodies, your dysfunctional immune system. Remember, the immune system has a innate immune system. We have the adaptive immune system. Learned a lot about the adaptive immune system in COVID. Remember, the antigen presenting cell grabs it, or a macrophage grabs whatever the foreign substance would be, and then takes it to the adaptive immune system, which creates the T cells and the B cells. But something in there can go awry and create your body to attack itself. The other part of the immune system is that complement. It's been surfaced lately with the new geographic atrophies, Izervay and Syfovre, that we've been talking a little bit now about the complement factor system, and don't have to talk about it too much here, but the immune system is pretty important. It goes dysfunctional and it produces these thyroid receptor antibodies. They are attacking the receptors at the thyroid gland. So they could be thyroid stimulating, thyroid blocking, thyroid peroxidase. You can order labs for thyroid antibody testing. Now, I like ordering it whenever I have this kind of, case that's been smoldering, the patient's not sure. Why am I on Lotamax? Why am I on Doctor in a Bottle, Maxitrol, Tobradex, on and off, monitoring pressures? How come I have this dry? Well, that's not it. Those are the cases that I was missing or that were being referred in. I'm like, well, doc's doing the right thing. Just got to keep you on steroids and monitor. But it was truly the soft tissue involvement from these antibodies that were attacking the orbit. Now, here's the lecture, the cat out of the bag, right? These antibodies that I have on the screen here, thyroid stimulating, thyroid peroxidase, thyroid blocking, they attack the receptors of the thyroid. So how does it attack the eye? How does it attack the orbit? Here's the lecture right here. Here's the rest of it, and then we'll go through and we'll point out and show slides, is that unfortunately, the structures and tissues that are found in the orbit have receptors that look like thyroid receptor. So now what's found in the orbit? The two main components, fat and muscle. And then if you get to the kind of the outer segment, you're talking about now the conjunctiva and the cornea. So cornea, conjunctiva, lacrimal gland, fat and muscle predominantly are the two tissues that have these receptors that look like thyroid receptor. So now you have a dysfunctional immune system, right? Autoimmune, and now it's attacking thyroid receptors. And I'm always sensitive when I talk about this because 1 in 13 people have a thyroid dysfunction. So someone on here tonight I know has this autoimmune condition where it has attacked the thyroid. But the good news is it doesn't always find the orbit, but in some cases it does. And that's where we have to be aware of this condition. So if you want to learn about the immune system, this is Ninja Nerd. This gentleman, I love listening to him. He teaches the medical students. He draws on these whiteboards. I think the only thing he started with was what was in red here, talking about this blood cell. And then he talks about the innate immune system here. Here's the adaptive and the T cells and the B cells, and eventually makes the plasma and the antibodies. And then right here is the complement system. Again, that's with the geographic atrophy. So you can listen to this 8-part series and really brush up because it will really help you with the autoimmune, We'll help you with the biologics that are out there being produced, and just overall understanding adaptive, innate, and the complement system. So you can see here, down here in this, when he's drawing this out, here's the innate crossing over to the adaptive. You have this antigen presenting cell, then you have these T cells. So right in here is where we're going to talk about the T cell. And then what happens in Hashimoto's, you get that CD4 T cell, and then starts to differentiate into a plasma cell, but it produces antibodies. Over here, you can see in Graves' disease, this is Hashimoto's, these antibodies that now, here's the thyroid tissue, here's the thyroid receptor. Remember, that's where the thyroid stimulating is supposed to come down and plug in to produce the T3 and T4, but now we have antibodies being produced by our immune system, which again, we can go and try and figure out why that's all happening, but we're not going to talk about that. We're going to talk about that the immune system in this autoimmune is broken, creating these antibodies, attacking these receptors. And here's the kicker. Unfortunately, these receptors, where these antibodies plug in, we have them in our orbit, muscle, fat, conjunctiva, lacrimal gland, and that's how we can get that chronic low-grade inflammation. So thyroid stimulating attacks the gland, and what happens is that creates stimulating a boost of T3, T4, and then we get a decrease in TSH, and we were taught that that was hyperthyroid. What happens in thyroid blocking, if you get thyroid blocking from this broken autoimmune, it will attack the thyroid. It blocks it, decrease in T3, T4, increase in TSH, and that's what we were taught was hypothyroid. That's not how we diagnose this condition in the clinic, okay? So if I animate this and just ask yourself, which of this whole spectrum here is going to create thyroid eye disease? It's the autoimmune part, right? It's the antibodies, the immunoglobulin side of this, Graves, chronic autoimmune thyroiditis, autoimmune atrophic thyroiditis, postpartum thyroiditis. These other ones down here, excess iodine, toxic adenoma, lithium medication, surgically induced, like removing the thyroid. These are going to cause people to be on Synthroid. But I guess is what I'm trying to say. This whole slide here is going to cause people to end up on Synthroid, but which ones are the highest risk are the ones that are the antibody, these autoimmune, that's going to create the thyroid eye disease. So when someone comes into my practice and they're on Synthroid, I try to figure out how they ended up there. Did they have cancer? Were they radiated chemotherapy? Then I kind of exhale a bit, knowing that they're probably or less likely to develop thyroid eye disease. But if they come in and they're, say, oh my gosh, it was hot, it was cold, it was this, it was that, it lasted 2 or 3 years, they're at risk for thyroid eye disease. So Graves' disease here, as we were all taught, is a multi-system disorder of a triad, right? Well, it's a triad of infiltrative dermatopathy, infiltrative ophthalmopathy. This broken immune system, this overactive immune system is attacking. And, a lot of these immune issues are found in females 7-to-1. There's a genetic. Remember, I'm not going to go too in depth for the time, but remember the immune system is found on the X chromosome. So ladies are XX, guys are XY. So Joe and I really only have one chance of that X being broken. And that's why when you see a lot of these conditions, 7-to-1 women, because they could have a good X, but they have another chance of the other X being that genetic mutation. So in this case, these Graves' disease are going to be 7-to-1 women. But again, look, autoimmune disease, hypersensitivity, thyroid stimulating antibody. Hashimoto's, the most common found in the United States, and that's good, and I'll show you why here in a second, is you still have the antibodies formed, but you get that goiter formation. And you can see it's the anti-peroxidase or the anti-blocking that's highly associated with it. Again, antibodies, autoimmune, atrophic. This is basically the same thing as Hashimoto's. You just don't get the goiter. And then you can get antibodies formed for your thyroid during pregnancy, and then that can lead to a thyroid dysfunction. Now, I think we all remember that when you have thyroid, hyperthyroid, and let's just say that they're stimulating or just pounding those receptors, causing the T3, T4 to go high, nervousness, palpitations, hypertension, maybe some diabetes, tremor, tachycardia. Remember, we're running really, really fast. Or if you're hypo, okay, cold intolerance, I feel a little weak, a little lethargic, maybe some bradycardia, that monotone, deep voice. I think we were all taught that. Now, thyroid eye disease, there's many names. Graves' disease should really be if the person has thyroid eye disease, if they had hyper. So, but I like these other ones, thyroid-associated orbitopathy. Thyroid orbitopathy reminds us it's in the orbit, and you're going to see that here in a second. Inflammatory eye disease. It's an inflammation. These antibodies are attacking the receptors, are attacking the fat, the muscle, the chronic low-grade inflammation that's out there. So endocrine orbitopathy, thyroid-associated orbitopathy, inflammation, all good names. But I think the most accepted is thyroid eye disease that's out there. So why is it confusing? Because it can happen in conjunction with Graves' disease, Hashimoto's, hypo, and like my guy that walked in, no evidence of thyroid dysfunction. So most thyroid patients, however, will not develop thyroid disease. Okay, because even though it's attacking the thyroid, it just never finds that orbit. But sometimes the immune system says, hey, look what I found up here, receptors that look like thyroid tissue, and it can attack. Now, this should make sense. While the eye disease may be brought on by thyroid dysfunction, successful treatment of the thyroid gland does not guarantee the eye will improve. So that means as you're managing the T3, T4, TSH, and synthroid, that's not the issue. The immune system that's attacking the gland and those receptors are causing ups and downs and this and of the T3, T4, TSH. That's not what's really causing the eye symptoms. It's whenever the antibodies find it. So managing them with synthroid and successful treatment doesn't guarantee that the inflammatory disease will improve. No particular thyroid treatment can guarantee the eyes will not continue to deteriorate. So that means managing the T3, T4, TSH. Once inflamed, the eyes may remain active for months to 3 years. Again, how broken is the immune system? Everyone's an individual. What's going on here? And that's why it gets so confusing. Thyroid eye disease, known as Graves' ophthalmopathy. Now, I always love to do this and say, okay, if everyone here tonight, it looks like there's 122 people here. If I said, hey, Craig Caldwell here tonight, I'm running this support group for thyroid eye disease. Hey, I'm glad everyone showed up here today. We all have thyroid. We're all on Synthroid. We all had thyroid eye disease. How did you end up? Well, where were you when you were diagnosed? Were you hypo, or were you a euthyroid? And we're going to talk about euthyroid. And the answer would be, if we were a support group, 80% would raise their hand if we were hyper. 10% would raise their hand if they were Hashimoto's, and 10% would raise their hand if they had a normal thyroid. Like the gentleman that I showed you earlier, hey, I keep getting tested for thyroid and it comes back normal. Why are my eyes doing this? Because he was euthyroid. We're going to talk about that. And that's why I said a little bit earlier, most of the patients come in and they are hypo in America, but that gives them about a 10% chance of developing thyroid eye disease. So I'm going to use the previous slide and this slide to tell you what I do in clinic. When I'm in clinic, someone comes in on Synthroid. Remember that one slide, where are they? Are they in the autoimmune part? Are they surgically, cancer, lithium? Okay, that's very low likely. Autoimmune, yes. Okay. When you were diagnosed, I try to figure out their symptoms. Were they hyper? Sometimes they know, oh yeah, I'm Graves' disease. Okay, that's my high risk. Autoimmune, Graves, 80%. Oh my gosh, no, I was freezing cold, this and that, hair falling out, blah, blah, blah. Okay, good in a sense, because now that puts them at a 10%. Still going to watch them, but it's not as high as that Graves and that thyroid patient that's out there. So, and that's what this is here, 10% function normalized, thyroid is a term, and I'll explain that here in a second. So what causes the thyroid eye disease symptoms? Well, I kind of fibbed a little bit. I have one slide in here. The rest of this whole talk is based upon these antibodies that are attacking the thyroid that eventually find the orbit. There are two phases of thyroid eye disease. When the patient is going through and they have the excess T3, T4, and they're hyper, they get some eye signs, and hypo, they get some eye signs, some stagnation of fluid. But treating that T3, T4, TSH will make those go away. This is where I want you to be aware. This is the story that I have that I like to tell. It's the story of, Mary comes in. I find out that she has thyroid eye disease. Maybe did some testing. She's been on Lodomax, Toberdex, Maxitrol, Lodomax, on and off, 18 months, monitoring the pressure. She has the soft tissue involvement. So she goes to her primary care doctor, and the primary care doctor says, "Hey, Mary, what's changed?" "Oh, Dr. Caldwell diagnosed me with thyroid eye disease." Let me look here. Oh, well, I look through Mary. I know Greg, and he's been in town for many years, very well respected, goes out and lectures, but, I'm going to maybe scratch my head here, maybe disagree a little bit. Your T3, T4, TSH has been the best for the last, 2 years. It's been steady. I haven't even had to touch your synthroid. I'm not quite sure how you could have thyroid eye disease. Remember, you have to separate the two. The T3, T4, TSH does not, they ended up on the synthroid because of the receptors being attacked by those antibodies. It's the antibodies that go and attack the orbit. And that can happen later after the disease. And that's why it gets so confusing at times. So there are some eye signs that happen with this free T3 and T4, but today we're going to kind of focus on the next 20 minutes on this congestive form of thyroid eye disease. And this is all changing now because of Tepezza. You can't really watch a TV anymore. I turn it on usually when I'm traveling, some background noise, and there always seems to be either geographic atrophy or a thyroid eye disease or Tepezza commercial on. And this active plateau and resolution is all changing now because Tepezza is turning that on its side. Here's the only slide I have on this T3, T4. This is not what the lecture is about. So when you do get that burst, when the antibodies are attacking the thyroid, hyper, you get that excess hormone. So you get that spastic stare, a little bit of dryness and lid retraction. Goes away when you normalize the T3, T4 with synthroid. Hypo, it's that hormone stagnation, congestion, hormone drops, you start getting impaired circulation, fluid stagnation, and periorbital edema. Okay, so that's the one slide that can happen. The rest of the talk is going to be about this congestive form or the inflammatory part. This is all changing again because we're able to intervene earlier with Tepezza, but there's an active phase, a plateau phase, a resolution phase, and it's really a low grade, maybe a higher grade at times, inflammation from those antibodies, stimulating, blocking peroxidase that have found the orbit. And unfortunately, the fat, the muscle, lacrimal glands, and tissues in the conjunctiva have these receptors that look like thyroid tissue, and it can attack. And that's why you'll hear it say burnout. I might have a higher number of receptors in my orbit than Joe. Joe might have a lower. So Joe only has thyroid eye disease for 6 months, where I'm going to suffer for 6 years as this autoimmune just keeps hammering away at all these receptors that I have. So remember, everyone's an individual, so that's why it can be long lasting for some, shorter acting for others. Some are more inflamed, some are less inflamed because there's an individually component to this. Now, this is what happens in euthyroid, and this is what we believe from the best minds that are out there, and I'm just kind of going with the best minds thing. Remember, if you get thyroid blocking, it's going to drop the T3, T4. If you get thyroid stimulating, it's going to increase the T3, T4. But what happens if you're getting equal amounts hitting that thyroid gland? Well, you're going to get a normal amount of T3, T4 based on this. Eventually, they're going to end on synthroid because those receptors get damaged, right? This is the part of the disease where it's up and down, this and that. And eventually, there's no more receptors to get attacked. But at this point right now, this person's producing the right amount of T3, T4, TSH, nothing showing up in the blood work, but yet they can get these antibodies attacking the orbit. And that's what happens, or at least that's what we think from the best minds that are out there, that's happening with a euthyroid. So my point is here, if you look at all these patients with thyroid eye disease, this one's here is a little bit more active, a little bit of redness, maybe a little bit of redness here and a little bit of redness here, but this one looks a little bit more, if you want to say, burnt out. All of these patients have had some form of these antibodies attacking the muscle, the fat, the conjunctiva, the fornix areas, the lacrimal glands with these antibodies that are out there. So here's a patient that came in. Hey, doc, I've been seeing these docs. PCP says, go see you. I've had these, I'm on and off this Lotamax. So can you maybe, tell me what's going on? So this was later after I unraveled this mystery, and that's why I want to share it with my colleagues, is that I look back and I see she's on synthroid. So I said, you know what? Let's just run a quick blood test and see if you have any of the antibodies. You can see here, thyroid globulin antibody less than 1, thyroid peroxidase 11, thyroid stimulating 344. And in hers, it said less than 1.3 is normal. As you can see there, I always joke, just a smidge high, right? Little question. 344 and normal is 1.3. Tons of thyroid stimulating immunoglobulin, right? Antibodies. And this is why she was having issues, but this is why she was having issues of her orbit. So I'll go through this pretty quickly. The ocular symptoms that we were all taught is the prominent stare, the lacrimation, eyelid swelling, foreign body, double vision. Just think about that. Those are all signs of low-grade inflammation. And eventually that inflammation can create muscles to swell, double vision. And then the decreased vision, when those muscles swell, can just crush that optic nerve in that muscle cone, as I'll show you here. So we were all taught no specs really has no use other than the fact that the patient can have no signs or symptoms. They could have upper lid inflammation, soft tissue inflammation. All these things are just signs of where this orbital disease, ptosis, extraocular muscle, cornea, sight loss can happen. Then we have the LEMO classification. Okay, it means lids, exophthalmos, muscle, and the orbits. So that's just, again, nothing that's out there that really helps us. Now, the clinical activity score, this is something that you might want to start, take a picture of. This is something that's going to help you with when to refer for TEPEZZA. Thyroid disease characterized by the severity and the activity. This is what they use to bring TEPEZZA to market. And this is pretty important to know. I don't have this hanging in my exam room. I just Google it. And when I want to examine someone or evaluate someone for the possibility of TEPEZZA, I do clinical activity score, and then I Google with thyroid, and it comes up. And what happens here, if you look, it says painful feeling behind the globe. You're just going to look at the first 7. This was for follow-up for Tepezza. These are all worth 1 point. Pain behind the globe, pain on attempted gaze, redness of eyelids, redness of the conjunctiva, chemosis, inflammatory eyelid swelling, and inflammation of the carbuncle or plica. Really, you only need 3 of these to make a referral, at least to have the discussion with them. The risk benefit, do you want to see someone that can do the infusion? So let me go through this pretty quickly. I want to show you the eye signs, and it should make sense of chronic low-grade inflammation. Lid lag, lid retraction, lag ophthalmos, right? This is all due inferior rectus scarring, infiltration of the levator. It's these antibodies that are hammering away at the orbital tissues. Lid lag, so much scarring, the eyelid stays up. Lag ophthalmos, the muscles are bulging so much, the eye can't close. This is where you're going to have patients. This is the one right here that I'm hoping you're writing names down, or you're going to log into your electronic health record tonight if you have access, or tomorrow. You're going to say, hey, look, I have patients with chemosis, periorbital edema, conjunctiva that looked like this young lady here that I thought was a chronic advanced dry eye. And you're going to look back and see they're on Synthroid, and maybe you'll order the antibodies. Now, the antibodies, they really don't help with the T3, T4, and the TSH and the Synthroid. It helps me to say, yes, this is your disease. I am going to be more aggressive with this. I'm going to put you on steroids. I might refer you for Tepezza, but if I put you on steroids, I'm going to follow you closer because I know it can create cataracts and IOP. So I like testing to help get my diagnosis, and that allows me to be a little bit more aggressive with my treatment and my follow-up. We start getting that optometric guilt. Oh my gosh, I'm seeing this patient, every 3 months. It's going to spark a trigger of an audit. No, it's not. You're doing the right thing, and you have it documented that's out there. So remember, here is SLK 65% of the time. It's related with thyroid. Well, there's your soft tissue involvement. But look, other autoimmune diseases, whenever it's not, collagen and elastin are the conditions of rheumatoid arthritis and Sjogren's, and that's why, again, that superior limbic keratoconjunctivitis can cause that type of finding. Andy Morgenstern, we just had our 10-year anniversary. He said, when the eye is red, think Ted. He was ever so correct. Periorbital edema, chronic signs of inflammation. Infiltrative orbitopathy, the muscles and the infiltration and those receptors being attacked. And if you look, lymphocytic infiltration, fibroblast, edema. It could be unilateral. It could be bilateral. And you can confirm it with an MRI, looking at the muscles. Look at this muscle here, how large it is, causing this eye to bulge. It's the chronic low-grade inflammation of this orbital disease. This is from Elsevier of 2005. Look at the muscle infiltration. That eye has nowhere else to go but out. Imagine that optic nerve potentially running through that muscle cone and being crushed. So compressive or ischemic optic neuropathy. So my patients that come in that are autoimmune, hyper, hypo, or euthyroid, I do exophthalmometry on. There are racial differences, but what we're looking for is a 2-millimeter difference between the eyes. And anything that's greater than 24, orbital disease consult, Tepezza consult, that's out there. Restrictive myopathy, double vision. The muscles are being inflamed. They're being fibrotic. Here is a classic case that can be very easily missed, but you can see the obvious muscle restrictive myopathy has an eye turn. Look at the periorbital edema and look at the conjunctival hyperemia. Corneal exposure can happen. I think we all know how to treat and recognize that. Optic neuropathy, 5% of the patients can end up with this ischemic or compressive optic neuropathy from this condition. So the treatment, this is changing all over the place because of Tepezza. I'm going to run through these quickly because I do want to talk about Tepezza tonight for about 5 minutes. So the treatment, I think we all know it's controlling the inflammation that's out there. So you can do lubricants, maybe Prism for the double vision, anti-inflammatories. There used to be a lot more orbital radiopathy and orbital decompression. All those numbers are dropping across the nation because of Tepezza. Anyone that has an autoimmune disease, please beg to have them quit smoking. They already got a broken immune system. They don't need those 2,000 toxins to create further damage. Again, the paradigms are shifting for this conjunctival and periorbital edema. We can be really aggressive with the steroids that are out there. We can do topicals and orals for the patient. If you start getting an optic nerve that is in jeopardy, you want to send for an orbital disease consult. Maybe someone like that's an adult strabismus doc that has double vision that's out there. Optic neuropathy, the steroids, the methylprednisolone, maybe to save that nerve. Maybe they do need radio therapy. That would be by an orbital disease specialist, just like there's retinologist in cataract. I have one in Pittsburgh and there's one in Philly that sometimes I have to send to maybe to get an orbital decompression. You can free up a lot of space by doing a 1 wall to 4 wall decompression, anywhere from 3 millimeters to 16 millimeters. So you can see here's some before and after pictures. Here's a before and here's an after. But we're not really doing a lot of this. Now look at this. This guy was missed because, and it was a year before Tepezza. But look at this thyroid eye disease that he has. You can see the redness, and I'm just going to put this up to help out. Do you think he has a painful feeling behind his eyes? Yes. Pain on attempted gaze? Yes. Redness of his eyelids? Yes. Redness of his conjunctiva? Yes. Chemosis right here and over here? Yes. Inflammation of his eyelid? Yes. Inflammation of the carbuncle and plica? He is 7 for 7. He was missed because he's a he and he's older. So you can see he had a restrictive myopathy over here in this eye. We had to treat him with steroids to the rheumatologist, and then I lost I lost his care because he ended up moving to Pittsburgh to be with his family. But you're going to see here that he improved. I sent him to the rheumatologist, and he started to improve. And this was a year before Tepezza came out. You can see the side effects starting to affect him with that moon face from the steroids. So polling question number 5, I just want to run that real quick, and then we're going to talk about Tepezza, and then we're going to wrap up this lecture here tonight. So let me open the question. I just want to see, have you prescribed or referred anyone for teprotumumab? As you can see, it says monoclonal antibody at the end for Tepezza. Yes or no?
No questions, Greg, so you're good.
Fantastic. So Joe, just going to run through the Tepezza stuff, and then we'll just land this right at about 9:50, and we'll do some housekeeping.
Very good.
All right. So to save about the next 4 minutes and 30 seconds, I see that the trend is in. I'll display it real quick. It is 18 people have referred for Tepezza. So about 20%. We have about 80% that have not. Maybe this will help with that in the recognition that's out there. All right. I'm going to close that and close the question. All right. So what is Tepezza? Tepezza, as you can see here, a monoclonal antibody. It's by Horizon, but it is now Amgen. They came out by Horizon. Amgen and Horizon just merged. And it is a biologic that is inhibiting the insulin growth factor 1 receptor. And that explains why you can get that glucose change while using this. So it was approved, and the worst month ever, right, out there was March of 2020. It was the worst month. That was the COVID year as the reminder. So let me show you what's happening here. These are right from their website. Remember, this is an orbital disease. And look how they're showing the inflammation of the orbit. And remember, we have the thyroid stimulating hormone antibody coming down and hitting the thyroid stimulating hormone receptor. But pretend this is fat. This is muscle of the orbit. Then you have the other side of the receptor, which is the insulin growth factor 1 receptor. This beta arrestin makes this all one receptor. So even though your antibody is coming over here and hitting this, it takes the insulin growth factor autoantibody hitting this to turn this on, and that's what creates the inflammation. You would think the logic would be to block this side, but what teprotumumab does is it comes over and bumps this antibody off, this insulin growth factor 1 autoantibody, knocks it off. This can still come down, but it down regulates this. It takes both of these antibodies to create this inflammation. So whenever you occupy it with Tepezza, which remember is an insulin growth factor 1, that's how you can get the resolution of the orbital disease that's out there. So what we're doing with Tepezza is quieting down the orbit with a biologic, right? So I think we're all familiar with Remicade and Humira that's out there. They're kind of the big boy immunosuppression. And if you ever watch a commercial on TV, you'll see that if you prescribe it, it's got this whole laundry list of side effects. Well, Tepezza is more immunomodulatory rather than immunosuppressive. It still comes with its side effects, but remember, it's a insulin growth factor 1 inhibitor. It's a full humanized monoclonal antibody, means it's mimicking the exact what's in our bodies. And what it's doing is working on the orbital fibroblast, myofibroblast, and the fat tissue, and regulating the inflammation and the amount of water and hyaluronic acid that's happening in this inflammatory condition called thyroid eye disease. So they did studies on it, looking at the clinical activity score, looking at proptosis, using the clinical activity score, looking at proptosis, diplopia, and Graves' disease. And there was improvement of 2 millimeters or more. There was diplopia scales being looked at and the Graves score that was out there. And obviously it came to market. So of the improvement of 2 millimeters or more was 83% of the patients. We have the scale of diplopia of 0 to 3. We had diplopia improving. And then the clinical activity score, which is quality of life, 0, my life is great. 100 is my life is terrible. And people, when they were on it, improved 17 points. So that's how this medication came to market. So the adverse, it's very well tolerated. We have some hearing loss that have shown up, and it shows that the people already had hearing loss can lose it some more. If you have good hearing, it's not really causing hearing loss. So that's why some people go and get hearing tests, or some of the infusion centers will test for hearing loss beforehand. But you can see here muscle spasm, nausea, diarrhea, fatigue, hyperglycemia. And that's the one I want to talk about, because remember, this is working on the insulin growth factor 1. So it can create hyperglycemia. The good news is it's not hypoglycemia, because that's what can kill the patient. So I'll just wrap up by saying, maybe talk to your rep, go to the Amgen/Horizon. The integration is going through right now. And you could hit the contact us button and you can ask for the questions that's out there. So with that said, Joe, I think that's a good place to stop for the thyroid part. And I'm just going to see if there's any questions, and I'm just going to advance my slides.
I don't see any. But the survey is up.
Fantastic. So I'll share these slides right here. right. So there's the survey button right there. It's all red. I can see it over there. If you click on that, you can start the survey for thyroid eye disease, GCA, and ocular myasthenia gravis. Joe, I think you said there's no questions, so I'm going to thank everyone. I'm going to thank you for being the dance partner for the GCA and the ocular myasthenia gravis in this autoimmune alphabet.
It's really good to split this with you, Greg, and really share rather than just making comments as we do for each other when we're doing solo. It's really good to join together and split it 50-50. And I really enjoy hearing your thyroid eye disease, your thyroid talk. I mean, Greg, it's really your Sergeant Peppers, so it's really your best.
Thank you. Thanks, Joe. Oh, looks like there's a question here. Is that just the thank yous coming in? I don't know. I just saw the little red button. I'm just not sure.
I'll take a look.
Take a look.
Question: Are TIAs an emergency or urgency? That would probably be kind of a separate question. Yeah, they are. TIAs are emergencies. If you think a patient has a vascular TIA, which is what we used to call amaurosis fugax, but you don't use that term anymore. Yes, that is a person who may portend a catastrophic stroke. TIAs that you think is due to retinal arterial ischemia, those go to the ER/stroke unit.
Great question. Really, it wasn't a part of tonight's, but certainly an important question for our attendees to know. All right. So we'll wrap up the CE. Joe, again, thanks for sharing, and thanks everyone for attending GCA, OMG, TED, the autoimmune alphabet.